Okay, good morning. Welcome to our Safe and Healthy Schools webinar series titled Student Head Injury Response Throughout the School Day. I'm Kendra Muir, School Nursing Wellness Specialist for the Utah State Board of Education. There are a few items of business before we begin. A recording of this webinar will be posted to our Safe and Healthy Schools events and trainings webpage. There will be a question and answer portion at the end of the presentation. If we do not have time to answer your questions, you can email me and our information will also be provided at the end. You may submit questions in the chat box at any time during the presentation. We look forward to having you join us for future webinars. We have two topics for June: equitable and culturally responsive schools on June 8th from 3:30 to 4:30, and restorative practices in addressing and responding to Utah school behavior issues on June 22nd from 11 a.m. to 12 p.m. Today, you'll be hearing from Dr. Fong and my colleague Betty Sue Hinkson, State Nursing Consultant for the Utah Department of Health. Participants are eligible to receive continuing nursing education credit or relicensure points. Nurses are awarded 1.25 CNE credit based on 100% attendance and completion of the evaluation. It's important to note that no individuals in a position to control content for this activity has any relevant financial relationships to declare. One relicensure point or hour is also available for participants to complete the required content questions and evaluation questionnaire. To receive credit for this webinar, visit the events and trainings section under the Safe and Healthy Schools Department on the Utah State Board of Education's website. The link for the questionnaire will be posted and available for 1 month from today. During the introduction, we will be polling the webinar participants, so if you have a cell phone, please have that handy. You can also access the poll through the internet. Let's begin. According to the CDC, the leading cause of death for children under 18 is accidents or unintentional injuries. Currently, most schools in Utah do not have a full-time school nurse, and school staff generally are the first responders to head injuries. Earlier in the school year, a phone call was received regarding a student head injury during school hours. After the injury occurred, the student went to the front office, received an ice pack, and was sent back to class. Later, the student returned to the office a second time, complaining of symptoms, and was sent back to class again. When the student went home after school, the parent, who's a medical professional, noticed that their child had signs and symptoms consistent with a concussion. The parent reached out to the school, upset that they were never told about the incident. When I began researching the policies and guidelines in place for head injuries, this is what I found. The Protection of Athletes with Head Injuries Act became part of Utah state law in 2011. It requires LEAs to adopt and enforce a concussion and head injury policy. It also requires concussion training, annual parent notification, removal of a child from sporting events when a concussion or traumatic head injury is suspected, and receiving medical clearance from a qualified healthcare provider before returning to play. The Utah State Board of Education is tasked by the legislature to make administrative rules regarding areas that affect education. Following the Student Head Injuries Protection Act, USBE passed R277614, which required training for coaches and other staff that supervise students, an annual parent notification, removal of students from sporting events following a head injury, and written clearance by a trained qualified healthcare professional prior to returning to play. After further research, I found that 76% of reported head injuries occur during the school day. The data in this slide has been provided by the Utah Department of Health Student Injury Report for school years 2016 through 2017, 2017 through 2018, and 2018 through 2019. Schools voluntarily report student head injuries to the Utah Department of Health for students who miss a half day or more of school and or those who receive medical attention for their injuries. The current law and administrative rule that we went over in the previous slides only protects student athletes and students in PE class. They specifically exclude free play, which includes other student activities throughout the school day. So of the 76%, where do you think most student head injuries occur during school hours? I'd like to hear from our webinar participants in this activity. So to access the poll question, you can either use your smartphones or computer. And when using your smartphones, text SHealthy281 to the number 22333, or on your computer, go to pollev.com/SHealthy281. So once joined, either choose A, during and between classes, B, lunchtime, including lunch recess, or C, all other activities, including regular recess. We'll give it another 5 seconds or so. Okay. Great. Okay, so what we found was that most head injuries during the school day actually occur during and between classes, and that includes class time, class changes, and then also remember one of the classes would be PE, which is physical education, and all the physical type classes as well. Um, so that's what we found. We found that that was very interesting, and that also there was not a board rule or a law that protected those students. In a joint effort, the Utah State Board of Education and the Utah Department of Health created a head injury work group made up of stakeholders from around the state. The work group was tasked with amending Board Rule R277614 to include all students through the school day, including during free play, a broader definition of head injury to include head bump, and required parent notification after each reported head injury occurrence. The work group has also amended the current model policy, which will replace the current head injury policy. And that includes the new board rule requirements and guidance for head injury response, including return to learn. To help schools through this transition, the work group created new resources to be used during a head injury response, including flowcharts and parent notification form. And these changes will be effective on June 8th, 2021. Our main presenter today is Dr. Fong. Alina K. Fong received her PhD in clinical neuropsychology with an emphasis on neuroimaging from Brigham Young University. During her academic career, she received the National American Psychological Association Graduate Student Research Award in 2004 for her research on cortical sources of the N400 and the N400 effect. Dr. Fong's interest in brain mapping soon turned to functional MRI. And since then, her research efforts have been focused on the clinical applications of fMRI. She has published numerous articles combining neuropsychology and neuroimaging and deriving data for various populations, including concussions, eating disorders, and moderate to severe brain injury. She completed an internship at the Veterans Affairs Salt Lake City Healthcare System, where she worked extensively with OIF and OEF veterans with both traumatic brain injury and post-traumatic stress disorder. In addition to her continuing research activities, Dr. Fong is the director of Cognitive FX, the premier concussion treatment center that utilizes functional neurocognitive imaging technology. She is a clinical neuropsychologist at Intermountain Healthcare and has helped to build the sports medicine and concussion clinic practices in Utah Valley over the last 16 years. Dr. Fong proudly serves as the Brain Injury Alliance of Utah president. She is a board member for the United States Brain Injury Alliance and serves on the Professional Advisory Board of Pink Concussion. I will now turn the time over to Dr. Fong.
Thank you so much, Kendra, for the introduction, and thank you again for being here. Can you see my slides? Can you see my screen? Okay, excellent. So what I wanted to talk about today was the prevalence of pediatric concussions and how serious they are and what some of the long-term implications can be and what we can do to help mitigate that. So pediatric concussions as a whole are much more common than we think. In fact, in this little infographic that we see here, almost 500,000 children are treated in an ED or an emergency room each year for TBI, and that includes concussion. That's more than 5,000 of the nation's largest school buses filled to capacity. Now, of these emergency department visits, 70 to 90% are concussions. And so concussions are actually the most common TBI, the most common traumatic brain injury that children are experiencing. Additionally, 50% of concussions are due to falls. In that same CDC study, in that same CDC study, they found that of those 500,000, a little over half of them were due to falls. And those are falls that are often occurring on school grounds and school property. So the CDC actually published a list of common causes, leading causes of concussions in children ages 0 to 14. Right there, it shows the 50.2% is, of course, falls. But then we have quite a few concussions that are related to, unfortunately, some motor vehicle accidents, struck by events, assaults, unfortunately, account for about 3%. And then, of course, unknown at 15.3%. Now, what this is not taking into account, of course, is the potentially hundreds of thousands of cases that are not being brought to the ER. And so the incident rate of concussions in our adolescent population is probably much higher than even what the CDC is reporting. This was a study by Araki et al. That was published in 2017. What I wanted to illustrate here was most importantly, on the right-hand side, what we can do, what we can do to help avoid these types of events from occurring. In toddlers and school children, most of the head injuries were accidental. They were caused by developing children. As we know with toddlers, they are more prone to falls. Their center of gravity, although lower, is not proportional. They are quite heavy-headed on a little neck and a little body. And so falls are much more prevalent. Of course, we have to increase the use of child safety seats. And with that, infant mortality and child mortality has dropped significantly. Pedestrian injury also increases in this age group. Lots of children, I know in my neighborhood, run around, we have a park right across the street. And we have, unfortunately, teenagers that are driving, and there are a lot of those types of pedestrian injuries that can occur. For adolescents, interestingly, a lot of these injuries are due to bicycle and motorcycle related accidents and some sports related head injuries. Importantly, on the right-hand side, though, are what can be done. Of course, the awareness of prevention must be raised. Trainers, players, those involved in contact sports will require education about concussion. But importantly, what I want to draw attention to here is that school staff, administration, nurses will also require education about concussion. And we're seeing this big pull now where the emphasis is taken from just sports in schools to general staff, because as the studies show, this is happening much more outside of just sports in schools. So we actually did a study with our population at my clinic, combining our data with cognitive effects as well as Intermountain Healthcare. I based the study off about 200 children from the ages of 7 to 17. What I wanted to note here were some of these reported instances of injury at school. Okay, so one was slipping on a wet floor. One was hitting her head. It was actually a girl hitting her head on a locker while someone kicked it closed. Of course, as a clinician, you're sitting here going, oh my goodness, what is happening? Why did that have to happen? The next one, cleaning up the baseball field and being hit in the head with a frozen dirt clump by another student. This other one I thought was quite interesting. A student threw a flagpole into the bleachers and struck my patient in the head. Another one is, of course, hitting his head with a football during recess. Bullying. I think this is an important one to note as well. With the increase of bullying that we're noting or that we're documenting that we're seeing in schools, we're seeing a higher rate of concussions due to physical aggression and assault in schools. Falling and hitting head on the side of a table, and that's at lunch. Falling off a slide and then falling backwards in a chair in class, during class, and then hitting the back of her head. So these are just some instances that we're seeing in school, and it can happen really anytime, anywhere to any child. Children and adolescents are particularly susceptible to the detrimental effects of brain injury. And that could be due to developmental reasons, neurologically, physiologically. It could be family dynamics, it could be puberty, hormonal issues, all of the above, which highlights the importance of effective brain injury recognition at the outset, proper diagnosis, and proper treatment. So some of the lasting impact of concussions are listed here. Our understanding of concussions has completely changed in the last 15 to 20 years. We no longer will say, oh, just go rub some dirt on it and go back. And, we've had to make a huge shift in our understanding of concussions as brain injuries. And so here are just a few examples of some of the lasting impacts that concussions can have. So schoolwork for these children can be very, very difficult. They could have difficulty completing their assignments, taking tests, focusing, learning new material. We can see changes in behavior and social development. We can see children that start acting out more or getting into drugs, getting into alcohol, cigarettes at an early age, and having more issues behaviorally. It can affect their physical growth and their development. We're seeing so many more cases now where concussions are affecting endocrine issues, hormonal production, thyroid problems, nutritional absorption, motor control as well. And of course, brain development, right? There can be drastic changes in their neural fatigue, nutrition, the way their brain metabolizes glucose and oxygen found in blood, and how that's distributed and utilized throughout the brain. Okay, so here we go. What I wanted to list now are some possible medical issues after a traumatic brain injury. I know this list is long and extensive, and it doesn't even cover all the medical issues that we're seeing, but I do want to cover a few, and I'm going to talk about one in particular in a bit more detail that is coming to light more with current research. So of course, many of us are familiar with headaches. Post-traumatic headaches are a very common reported symptom after a concussion. In some more serious types of head injuries, there could be swelling in the brain. There could be problems with the hormone or the endocrine system. There could absolutely be gastrointestinal issues, nutritional absorption problems, motor issues, balance, of course, vertigo, difficulty with the vestibular system there. Breathing and respiratory problems. There could be even blood clotting disorders. Of course, cognitive issues, with the main focus being on attentional problems, memory, and executive functioning disorders. And in some cases, also seizures. We're seeing quite a few instances of post-traumatic seizure disorder in these children, and of course, psychological disorders. One more that is not on this list that I do want to bring up as well is vision. We're seeing that vision issues, whether it's ocular motor or in the eye, or occipital, right, with the visual processing center of the brain, we're seeing that a vast majority of these children are reporting visual processing problems. They'll often go to their optometrist who will do a basic vision test, and they'll still be 20/20, but they're having problems with focusing with screens, convergence and divergence of the eyes, headaches occurring because of difficulty with reading. So these are some things that I'd like you to maybe pay attention to if you're having a child complaining about these things after a concussion. It's not always just a 20/20 issue. The last one that I'm going to cover in more detail is autonomic dysfunction, and it's actually at the top of the list here. Autonomic dysfunction is problems or difficulty with our autonomic nervous system. So our central nervous system consists of an autonomic nervous system, and that nervous system actually is broken down into two branches. We have the sympathetic, and then we have the parasympathetic branch. The parasympathetic and the sympathetic, as many of you know if you're school nurses, work well together and they balance each other out. So we have fight or flight. We can have, which I'm sure you've heard of, rest and digest, right? So we have these automatic, which is why it's called autonomic. We have these automatic bodily responses that respond to trauma and respond to our environment. What research is bearing out now is that many of these concussion patients, especially children, can have difficulties with their autonomic nervous system that can lead to longer lasting physical issues. For example, the autonomic nervous system regulates digestion. And so if these children are now having gastrointestinal issues, Many of them will say, the food doesn't taste the same. I just feel sick and nauseous. I don't want to eat. You'll see weight loss. Sometimes you'll see weight gain. The autonomic nervous system also controls heart rate and blood pressure. We're seeing a number of children, adolescents that are being not necessarily misdiagnosed, but not completely diagnosed correctly, and are being diagnosed with POTS or blood pressure issues, and then being put on blood pressure medication when it's actually a dysregulation of the autonomic nervous system. We can see kidney and waste management issues, again, hormone imbalances, sensory processing issues, and also headache. So for those of you who are interested, if you go onto Google or on PubMed and look up dysautonomia and head injury, you'll see a plethora, a litany of research that has just been done in the past few years looking at the autonomic dysfunction. So implications for school. Here's what's interesting. Of the same 200 patients from the ages of 7 and 17 that we studied, we looked at the top 5 symptoms with these children. Number 1 was difficulty concentrating, focus and attention issues. The second was headache. Third was memory problems. Then feeling tired, mentally foggy, brain fog, and then being slowed down. What I want you to notice here and kind of take note of what you might be thinking is, wow, most of these are cognitive. What implications will these long-lasting symptoms or top 5 symptoms have in a school setting, right? Well, I think there's definitely going to be some implications for returning to learn with these patients. This actually is a great graphic that I like to use when talking to my patients about how their brain is functioning. On the left-hand side, I like to say that this is a brain that's never been concussed. That brain can get from point A to point B very efficiently, using the most efficient streets possible, maybe just using the highway, the freeway to get from one exit to another. On the right-hand side, though, this is a good illustration of how, even though a child might still get the right answer on a test, or might still be able to answer that teacher's question correctly, that child had to take every side street known, very inefficient pathways, and had to utilize a lot more resources to still get that same answer. Okay? So even though you can't see the injury, concussed brains have to work overtime in order to get that right answer. Okay, so this highlights our need to cater to a patient even when they look normal and potentially need a 504 plan. I'd like to take a second and talk about Sarah. It's always better when I can personalize this and bring a real patient into this. So we're going to call her Sarah. She was a 17-year-old high school athlete. And interestingly, she fell off a broken cafeteria stool and hit her head on the edge of the stool behind her. So she actually just caught her kind of the back of this occipital area right there under her skull. She went straight to class afterward. Even though she said she reported that she felt wobbly, she was going to black out, she actually went to class, and her teacher noticed that she was walking unsteadily and wasn't quite the same. The teacher said, "Hey, Sarah, are you okay? What happened?" She said, I'm fine. I'm fine. I think I hit my head and I think I'm fine. And the doctor said, okay. The teacher said, okay. But she continued to not feel well. She finished that class, finished the rest of the school day, continued to not feel well. She went home. She went home and her mother said, "What's going on? Something's very wrong with you." And her symptoms worsened and worsened to the point where she began to slur her speech. She just was not the same. The mother took her emergently to the ER because she still had a headache, slurred speech, and then she had light sensitivity. What I really want to point out here is that symptoms progressed, and we need to monitor these children in order to be able to see these symptoms progress. So as time went on, Sarah also reported headaches, fatigue, nausea, light sensitivity. She had some visual blackouts, numbness and tingling, brain fog, slurred speech, memory problems, the attentional issues. Then her mood started to become affected, emotional dysregulation, and irritability, all while still trying to do treatments and go to school. So she was a sophomore in high school. By the time we saw her, she was 17. I'm sorry, that was a misprint. But just as a summary, she not only went to her local concussion clinic, but she also went to her pediatrician, a neurologist. She was put on several medications. She did paper pencil neuropsych testing. She went to see neurosurgery at UNC, Utah Neurological Clinic. She saw a spine specialist, OT, vision, and she even flew to North Carolina to go to a Duke Children's Specialty Clinic there as well. She's been put on many different medications, numerous imaging, lots of negative test results, overall culminating in about 3 lost years of symptoms and missed activities. Now, of course, this is not typical for every patient, but Sarah struggled quite a bit. So what I wanted to highlight is what could we have done better? What could have been done better? Well, first of all, we need to have proper documentation, which is really what sparked this change in this amendment. We need to educate staff on concussions, what they mean, and why we should monitor these patients over time, these students, to see for symptom progression. We need to properly document these events. Luckily, this wasn't a case where the parents were litigious in any way, shape, or form. That's the biggest thing we want to avoid, right? Is number one, making sure that the student is safe and healthy and gets the right care, but we also want to avoid any culpability or any type of risk that the school could be put at. So properly documenting when these things happen puts the school and staff in a much better position. Secondly, we have to inform the parents when it happens. Parents are the best judge of their child's symptoms and really any significant changes that need to be addressed immediately. And I think really importantly, we need to educate the students too, right? Sarah didn't know what was going on with her. I mean, she may have guessed that she had a concussion, but she's still a child. But the more that we can educate these children on what some symptoms are and when they should say something and when they should maybe even advocate for themselves, the better. So the more we can all be educated and work as a team, the best for the school, the parents, and especially the student. I hope you're getting the picture here that we're trying to drive this point home. Parents and guardians must be notified following each event. They are the best person to notice changes in that child's personality. And we also need to document. So why? Well, proper documentation and early reporting can save the school from a possible lawsuit. It could save parents drowning in medical bills, and it could, more importantly, save that student from a 3-year-long recovery, falling behind in school, missing school days, and losing years of their life as well. So this is why the model LEA concussion and head injury policy was amended. So as Kendra mentioned before, the main changes are threefold. They include all students and free play. So for example, it reads, any student with a concussion may have one or many of these signs and symptoms that are listed in the LEA policy. Any student who exhibits signs, symptoms, or behaviors consistent with a concussion shall be immediately moved from the contest, game, practice, or activity and shall not return to play until cleared by an appropriate healthcare professional. And then again, we state parent notification must be made for any and all suspected or witnessed head injuries. Also, we included a head bump as a definition, as well as the notification. So any student in free play, including a head bump, and parents need to be notified. What we also added here was a return to learn rather than just a return to play. What I like here is the role of a team approach to this. So we need to counsel with the team to gradually increase intensity of academic activity, monitor symptoms and academic process, and adjust accordingly until academic performance has returned to pre-injury levels. Interestingly, in sports medicine, where I'm housed, we've been practicing this already. In fact, whenever we get an athlete in, we always say, you are a student athlete. What word comes first? Student, not athlete, right? So we always try to get that student back into school as well as back into play. But what I really want to note here is the word team. And what I really want to maybe drive home is that this team may need to consist of a nurse, a counselor, a school psychologist, maybe even a teacher, teachers, and principals. This team needs to be kind of a multifaceted approach to understanding that individual student's overall needs. And then I also wanted to add here some common accommodations for children with traumatic brain injuries. These have come from my notes and my letters specifically that we often provide to school counselors or to accommodation centers to help that student matriculate back into an academic learning environment. I want to just close my section here with a few, I'm actually gonna pass it to Betty Sue, and who will give us a bit more information about some of the policies and close our webinar.
There we go. I couldn't find my mouse to unmute myself. While Kendra brings the slides up, thank you everyone for attending. And while I'm thinking of it right now, I'm putting the
You're muted.
sorry, I don't know why that happened. I was nowhere near it. Okay, so as Dr. Fong mentioned in the amended policy, there are 3 things that we wanted to stress in particular. The documentation is really critical. So whoever responded to that student, whether it's an actual first responder, a nurse, a secretary, a playground aide, should document what happened. And this is critical to protect the school and to potentially initiate any academic accommodations that might need to be made for that student. Schools might need to look at how the school nurse is notified of injuries that occur when the nurse isn't present. So we know that not every school has a full-time school nurse. And so many of these accidents are going to occur when there's not a school nurse present. And we don't want, what we want is that each school will have some kind of a policy or procedure in place on how to notify the nurse, whether it's a phone call or a text or filling out an accident report and putting it on the nurse's desk so the next time they can check it, an email, whatever process works the best for your particular school and setup. You need to have some kind of process in place to make sure that school nurse is notified of any head injury, so that nurse can follow up with the parent guardian, see if the student needs a healthcare plan, see if the student needs a 504 plan or connection to any resources. So that's really critical. And then the final amendment we made was that parent notification is made on all reported head injuries that happen during school hours. We're not talking about athletic events and a student who plays football and gets hit repeatedly during a football game. We're talking about these that happen during the school hours, during recess, during class changes, in the hall, falling off the stool in the lunchroom. If the student doesn't report it, you are not required to do anything about it, but we're not advocating that they not report it. We want them to report it so that we can notify the parent for each event. Next slide. So to facilitate this, we created 3 different forms. This first one is a head injury flow chart, and this is designed specifically for lay staff to follow. And it's in a very simple, if you see these symptoms, these are the actions that you would follow through with. So for example, under mild symptoms, if the student reports mild pain, bruise, you see a bruise, they're answering questions appropriately, they're oriented to person, place, and time, then following what we've already mentioned, you would notify the parent and guardian. You would complete the concussion checklist, which I'll go over next, and then document the care provider. Optional would be applying ice. And then if you go a little bit further into the right, there's moderate symptoms, so a little bit more severe, swelling, goose egg, vomiting once or twice, a little bit more obvious symptoms, and then the action would be similar: contact or notify the parent or guardian, and suggest that they pick their student up so that they can watch them. The staff should be completing the checklist, and anybody that falls into this category, we would urge medical care. Again, document care provider provided and apply ice. And then the more severe symptoms, vomiting more than twice, any loss of consciousness, any of the items in that far right column, we would ask that you call EMS or 911 and do that first, and then notify parent or guardian. Again, complete the checklist and document the care provided. Now, it's expected that if the nurse is present, it would be the nurse that would evaluate the student, and the nurse may or may not follow this flow chart. As I mentioned, this flow chart was designed for lay staff. Somebody with any kind of a medical training or background may choose to follow different process. The nurse may follow this, but the nurse may also use their professional nursing judgment, which may lead to other actions. Calling EMS sooner, urging medical care at a different point. But any school staff that is not a nurse should follow this staff if they're evaluating the student. Okay, next slide. Now, this is the checklist we developed based on the CDC signs and symptoms checklist. And that reference is there at the bottom if you want to see it. So every time a student comes into the office with a head bump, and I know you get a lot of them, but the potential is there for problems. And so really, to protect yourself, protect the school, and to give the student that had the head injury the proper treatment, we need to be monitoring what happens to a student that has a head injury while at school. So this is going to be, should be filled out for any student that comes in with any kind of a head injury or head bump. You would fill the top part out with their demographic information, a brief description of what happened, and then the resolution, what you did. Did they go back to class? Did they go home? Were they referred to a healthcare provider? And then the signature of whoever completed this form. And then the checklist below. Now, it's important that a student with any kind of a head injury be monitored for a minimum of 30 minutes. And I know what you're going to say. But as we heard from Dr. Fong, you know, symptoms can progress, and even something that seemed minor at the beginning may end up being very significant. And we do not want our school staff to be burdened with evaluating the student or assessing the student. They don't have the skills, they don't have the background. So to protect everybody, we are requesting very strongly that you observe this student for a minimum of 30 minutes. And every 15 minutes, just kind of put a check mark. Do they appear dazed? If they do, put a check mark there. Repeats questions or answers questions slowly. Can't recall events prior to or after the hit, bump, or fall. Loses consciousness even briefly. Nausea, vomiting, blurry double vision. Student reports not feeling right, feeling sluggish, hazy, foggy, or groggy. And then again, prior to leaving, if the parent chooses to come pick them up. Now, this should be completed, as I said, on any student with a head injury, and a copy should be made and sent home so that the parent is aware of what happened. And on the other side of this form, next slide, please, we developed this parent notification form. So print these 2 pages off front to back. Checklist on one side, parent notification on the other side. And so this gives instructions to the parents on what signs and symptoms to be observed, or what signs and symptoms that they can observe in their student, and signs and symptoms that might be reported by the student. And then there's another category at the bottom that are danger signs, that if you're not calling 911 on a student and you're urging medical care, that these are the things that a parent should be watching for. Now, this is different from the flow chart. Remember, the flow chart is for school staff to use to evaluate. We're not asking the parents to use the flow chart. We want the flow chart to use this document and watch for these particular symptoms. And then if they feel it's warranted, take the student into a healthcare provider. This will help limit the school liability. It'll ensure parent notification, and will also help with providing appropriate accommodations to any student who might need those educational accommodations. Any questions on any of this so far? So let's go ahead and go to the next slide.
Betty Sue, I did have a couple questions. I wasn't sure if you want to answer them now.
Yeah, go ahead.
There was a question about, what about nonverbal students?
I don't know. However, there are signs and symptoms that you could still observe, even on a student who is nonverbal. But the reported by, of course, you're going to have to modify how you assess that student for their responses. Dr. Fong or Kendra, do you have anything else to add on that?
Yeah, my response is, if you actually have a nonverbal student, you should have most likely you should have a parent that's probably more involved than maybe the average parent, right? And I would say call that parent right away. You know, that parent might be the best person to be able to elicit certain responses and see if there's been any significant changes in that child. And then, of course, just do the best you can with, you know, some of those nonverbal responses or some of those nonverbal evaluation or assessment pieces. But I'd probably call the parent more readily than I would for, you know, for a student that's verbal.
Thank you.
And the forms and flow chart that you have, is that available? Could you send that out? And also, is it available in Spanish?
I don't have it in Spanish yet. We can see if we can get, I'm not sure if we have access to that. Tina, do you know that? Do you know if we have somebody who can translate these?
We do. Sorry, this is Kendra. We
Okay.
have someone, and we will translate those.
Okay, and then they will be posted on both the USBE Safe and Healthy Schools website as well as the EPIC website. We just haven't done them yet because we wanted to introduce them to everybody here first.
Okay.
Any other questions? Now I realize, I see the comment that watching a student in the health office for a minimum of 30 minutes is going to be difficult. We understand that, but the risks of not doing it are very high. So I would urge you to try to figure out a way to make those adjustments in how you manage the students. I've been in schools. I understand that it's going to be difficult, but we also have had way too many students slip through the cracks. Where if we had caught the injury a little bit sooner, it would have potentially not been as dramatic for the students. And another point we wanted to make is that when you are encouraging that the parent take the student in for an evaluation, that it be with somebody who has experience dealing with concussions or head injuries. Obviously, a chiropractor is not the best choice for a student with a head injury, and a podiatrist wouldn't be, and not your neighbor or your brother-in-law who is a doctor. Take them into somebody who specializes in that so that the student can get properly diagnosed and treated. Sorry, was there another question?
There was just one about nurses are not able to diagnose. And I don't know if you saw that one comment where they've recommended to a parent to go to a qualified healthcare professional. And they're wondering why aren't they the ones, can't students evaluate and such?
Well, yes, so those two comments go well together. Often we contact parents and tell them that they should go to a qualified healthcare professional. Yes, nurses are qualified healthcare professionals, but they are not healthcare providers. That's the difference in the term. A provider can diagnose and treat. A professional can assess, and we are recommending treatment from a healthcare professional. Nurses cannot diagnose, but they can assess, they can see symptoms, and they can recommend treatment, seeing somebody with experience treating concussions or head injuries. And then that person, that professional, that provider can give the specific treatment that should be done. Is there anywhere in the law that states the school nurse cannot diagnose a concussion just for backup when these situations occur? Well, that is, I'm not sure where it's stated. It's not stated in the law, but nurses cannot diagnose anything. So we can assess, and we are not treatment providers. We assess the situation.
Not to say that there aren't many, many nurses out there that could probably diagnose better than other doctors, right? But it's what you're used to seeing, right?
Right. They're not able.
Yeah, and school nurses don't have all the necessary equipment they would need in the schools either.
And one thing I would say to that comment is that it's not just, diagnosis is important, right? But like I said, it's recognition, diagnosis, and treatment. And there's no school nurse that's equipped or has the time to devote towards treating a concussion case like this, right? I mean, sometimes you'll need to farm them out to, I mean, I do this all the time. I'll have to farm them out to, a vision therapist and manage their care and send them to an OT and a neuromuscular therapist and a physical therapist and a vestibular therapist. School nurses don't have that capacity. They don't have the time to do all that. So that's why it's important to send them to people that specialize in that.
Yes. So for you school nurses that are in attendance, we will be sending an email out with these forms that we have in English. We don't have them in Spanish yet. And then they will be posted on both the Department of Health EPIC website and then the Safe and Healthy Schools website. And we will send those links out. For those of you that are not nurses, if you are familiar with the Safe and Healthy Schools website, just watch that, and that's where they will be posted. And there's the link right there in the chat if you want to copy that and bookmark it now. Let's go to the next slide if we don't have any other questions. Here again is the link for the evaluations. I put it in the chat box. If you are a nurse, you would want the bottom link. If you are other school staff, you would want the relicensure link. Next slide. Kendra mentioned that we had put together a concussion, a head injury work group, and these are the people that we involved in that. So you can see it was quite comprehensive, and it was a really great group of people that helped us come up with thoughts and ideas that maybe some of that I wouldn't have thought of, or Kendra wouldn't have thought of alone. We initially didn't have Dr. Fong as part of the group, and somebody else recommended her, and I'm sure glad they did. Next slide, please. Here's a few resources. We took most of our information from the CDC's website, their Heads Up program, and then there's a link to Dr. Fong's program, Brain Injury of Utah, and then the Utah Department of Health TBI, or Traumatic Brain Injury program, has a few resources. And next slide. And here is our contact information. If anybody has any questions, we're happy to help. If there are no more questions, we can conclude this webinar.
Thank you so much for your attention.
There
Thank you,
are
Dr.
questions about wanting the links for the CE credits. Again, as far as the USB credit, it will be on our events tab on the Safe and Healthy Schools website. I will put that link in the chat.
Yes, and the nursing one was put into the chat too, so. And the CNEs, let me just, I forgot to mention this, the CNE evaluation will be open until 5 p.m. tomorrow night, and it will be for those people who attended this webinar today. For the archived webinar, if people watch it later, the CNEs will not be available for the nurses. Any other questions, comments? We're here to help you. If you come up with questions or ideas or thoughts or issues, let us know. And we'll see what we can help you with. Thank you everyone for joining. Have a great day.